You're in the middle of a chaotic pediatric arrest. Your memory is the first thing to go. The screaming, the alarms, the frantic energy of the room, it all works together to shatter your focus. In that critical moment, with the child's life hanging in the balance, relying on a memorized drug dose is one of the biggest threats to your patient safety. I'm Angry Bill. I'm a 30-year paramedic, and I'm going to tell you why the safest, smartest, and most professional thing you can do is to stop memorizing and start looking it up. Use a reference. This isn't about being lazy, it's about being better. There's this deeply ingrained culture in EMS, the myth of the salty medic. It's this idea that a truly seasoned provider has seen it all, done it all, and has every single drug dose and protocol locked and loaded in their brain. We've all seen that medic, the one who seems to run on pure instinct, never cracking open a reference. We're taught to admire that. We want to be that. But I'm here to tell you that this ideal isn't just outdated, it's dangerous. The funny thing is, it's how I was brought up. In the 1990s, when I went to paramedic school, I memorized a dozen different doses for epinephrine. Just one medication, at least 12 doses. And that doesn't include translating pounds to kilos, multiplying the per kilo dose, figuring out how much of the medication I need to administer based on the concentration in the vial, and then thinking through the process to make sure that the decimals are all in the right place and the dose is a reasonable one. And do it at 3 a.m. when I was dead asleep 5 minutes before. There's a frantic family watching. It's too much. I'm willing to admit it. It's flat out too difficult to be mistake-free for a long period of time. The reality of our jobs is that we work in an environment of constant cognitive overload. That's not just a catchphrase, it's a psychological concept describing what happens when the demands of a task exceed your working memory's resources. Think about your last critical call. You're managing the airway, watching vitals, directing your partner, directing the whole team, talking to the family, running through differentials, and trying to remember the correct epinephrine dose for a 10-kilo toddler? Your brain becomes overwhelmed. Of course it does. That can lead to mistakes or delays in decision making. This high stress, fast paced world is a breeding ground for human error. Research has shown that a high cognitive load makes physicians more likely to make errors in clinical judgment and decision making. Every interruption, a question from a parent, an alarm from the monitor, steals precious real estate in your working memory. It's a space you need for actual clinical decision making. When you get overloaded, your brain defaults to shortcuts and patterns, and that's exactly when mistakes happen. It's not a failure of intelligence or a lack of caring. It's a failure of a system that expects human memory to be a flawless computer in the middle of a hurricane. Nowhere are the stakes higher than in critical pediatric calls and in medication-facilitated intubations. For many of us, these are high acuity, low frequency events. We might go months without pushing paralytics or running a full-blown pediatric anaphylaxis. Yet we're expected to have those complex weight-based calculations memorized perfectly. The research on pre-hospital pediatric medication dosing is sobering. Studies have repeatedly shown that significant dosing errors happen, in some cases in over a third of pediatric medication administrations by EMS. A third of medications are wrong. Even with the implementation of printed dosing references, one study by Hoyle and colleagues in 2019 found an overall error rate of 31.2% in simulation, with a tenfold overdoses in epinephrine still occurring. Another study analyzing administrations in Michigan found error rates for some drugs were alarmingly high. Midazolam was dosed incorrectly over 50% of the time via the IV route, and fentanyl over 68% of the time. The leading causes are often simple math errors, dilution mistakes, and incorrect weight estimations made under pressure. This is especially critical in rapid sequence intubation. Getting the weight-based dose of a sedative or paralytic wrong can be catastrophic. Underdosing can lead to a failed intubation, while overdosing can cause profound hypotension or other adverse effects. One of the most terrifying scenarios is a patient being inadequately sedated while paralyzed, and experience one study noted it is real risk when using longer-acting paralytics like rocuronium. Some research has found that in cases of significant pediatric epinephrine overdoses, the average error was a staggering 800 to 1,000% of the correct dose. Let that sink in. An error of that magnitude is a burden no provider should have to carry. We need to shift the blame. The problem isn't the individual medic who makes a math error in a speeding ambulance. The problem is the institutional expectation that they should be doing mental math in the first place. Human memory is fallible. Pretending otherwise, where precision is the difference between life and death, is a systemic failure. The solution isn't just to study harder or be better. The solution is to evolve by integrating cognitive aids into our standard practice. This includes both printed tools like the Broslow or hand-heavy systems and electronic tools like validated smartphone apps. Let's be crystal clear. This is not a shortcut. Using a tool to verify critical information is a hallmark of a true professional. Airline pilots use checklists before every single flight. Surgeons use them before every single operation. They do it because they understand that systems and tools are more reliable than memory, especially when lives are on the line. This is where clinical decision support systems, CDSS, come in. It could be a simple, well-designed app, a digital protocol guide, or a pre-calculated, volume-based printed reference. These tools aren't designed to replace your clinical judgment. They're designed to augment it. They're designed to offload the cognitive burden of calculation, freeing up your brain to do what it does best. Think critically about the patient in front of you. A 2022 study by Rappaport showed that after implementing a field guide with pre-calculated doses in milliliters, the rate of correct pediatric medication doses rose to nearly 90%. Research by Kaufman in 2021 and others consistently show that using these tools improves dosing accuracy and reduces errors. Picture a chaotic pediatric seizure call. In the old model, the medic is scrambling. They're trying to remember the dose of midazolam. Is it 0.1 or 0.2 milligrams per kilogram? What's a concentration? Is this the 5 in 2 or the 5 in 5 dial? They're doing mental math while trying to get a weight from a frantic parent, risking an error. Studies have shown this is a common scenario for mistakes. Now let's run that same call with a modern, safety-conscious paramedic. The scene is just as chaotic, but instead of relying on a stressed-out memory, their partner pulls out a department-approved tool, whether it's a printed, color-coded guide or an app like PediStat. They can use a length-based tape estimate if a weight isn't available. They input the information, and in seconds, they have the correct dose in milligrams and, more importantly, the precise volume to draw up in milliliters. No math, no guesswork, just accuracy. The tool did the calculation, which freed up the paramedic to think about the important questions. Is this a simple febrile seizure or something more sinister going on? What are our postictal considerations? Is the airway protected? How's my egress to get out of here? The mental energy for the calculation was offloaded and redirected towards patient care. Some will argue, well, what if my battery dies? And what if the previous shift lost the dosing guide? It's a dumb question, but I'll answer it. It's why a professional always has backups. It could be a printed reference card like the hand-heavy system or your partner's device. The point isn't to rely on a single piece of tech, it's to build a system of verification. Others say it's too slow. Is it slower than giving the wrong dose? Is it slower than a failed intubation because you underdosed your paralytic? Absolutely not. Taking 5 seconds to confirm a dose is the fastest way to ensure you're doing the right thing for your patient. This philosophy goes way beyond just drug doses. The field of medicine is constantly changing, constantly evolving. A protocol you memorized 5 years ago might be dangerously out of date today. The 2025 AHA guidelines, for instance, have updated recommendations for early epinephrine administration in pediatric cardiac arrest with a non-shockable rhythm. Digital tools can provide instant access to the most current evidence-based guidelines from your agency, ensuring you're practicing to the latest standard. Adopting this mindset is about embracing a culture of safety and lifelong learning. It's about acknowledging that we're human and that our brains have limits. A national survey of paramedics found that 43% were familiar with a case where a pediatric dosing error occurred, and over half felt their initial training was insufficient. It's about having the professional humility to say, I'm not going to guess, I'm going to know. The best clinical decision support systems integrate right into your workflow, offering prompts and safety alerts without getting in the way. They can flag potential drug interactions or allergies, giving you another layer of safety that memory alone can't match. This isn't about being a robot. It's about using technology to be a better, safer, and more effective clinician. The bottom line is this: using a tool to verify information isn't a sign that you don't know something. It's a sign that you are absolutely committed to being right as much as you can be. It shows a level of professional and dedication to patient safety that should be our standard of care. We need to move past the outdated image of the salty street medic who relies on memory and embrace the image of the smart, modern paramedic who uses every tool available to give the best possible care. Next time you're on a call and you feel that moment of uncertainty, don't just push through. Don't guess. Take a breath, pull out your tool, and look it up. Hang on, I got to do that again. Take a breath. Take a breath, pull out your reference, and look it up. Your patient, your partner, and your own peace of mind will thank you for it. What's your go-to cognitive aid in the field, printed or digital? Share it in the comments below, and let's build a resource list for everyone. Let's learn from each other. And if this message resonates with you, hit that like button and share this with a colleague. Neither costs you anything, and I really appreciate it. Subscribe to the button below as well. Make sure not to miss the next video. I'm Angry Bill. This is Prehospital Wisdom, and until next time, minimize your errors and lighten your cognitive load. Stay safe.